Welcome back to another episode of the Rehab with Roni podcast. What's up, guys? I'm Roni. I don't know. It's 4th of July weekend and it's the end of it and I'm feeling a little tired. But I have this commitment that I made to myself to drop one episode per week for 52 weeks straight, equaling a year of a podcast episode coming out weekly. And I'm not gonna back down on that goal. So I'm here to deliver a solo episode. And this is going to cover a subject that was requested by a follower, and I thought it was really smart. In the past, I created an episode called An Initial Evaluation at Rehab with Ronnie, and I kind of walked audience through what it looks like to be inside of an initial evaluation in a cash-based PT setting, specifically in my cash-based PT setting, because I think it can differ a little bit from your traditional outpatient clinic. So I walked you guys through that, and she messaged me, this follower, and said, "Hey, I would love to see what a follow-up would look like in your clinic." And what better time to detail out that process than right now? I would like my disclaimer to be that this is just the way I do things. And I think as you grow and figure out what it means to be a physical therapist to you, your practice will change, your patterns, your tendencies. And right now, these are just what my tendencies tend to be. I think there are certain things that you definitely absolutely should cover, but I'm excited to get into the nitty-gritty of what it looks like at my clinic because over the past year and a half, I've started to refine it a little bit and I can just kind of give you guys all the fun stuff that happens. So let's get into it. For the sake of continuity, let's just say that I am seeing somebody. This is their first follow-up visit after an initial evaluation. So let's say they came to me on a Monday and we'll call this patient Mr. Joe. No, that's such a basic fill-in name. We'll call this person Mr. Mr. Jerry. Okay. I know way less Jerry's than I do Joe's. And Jerry, he came to me on Monday with a torn labrum. He was doing a squat snatch at CrossFit, overextended through that right shoulder. Bar went backwards, chest went forwards. Kapow! Torn labrum. He's been to his doctor already. He got the MRI. They said, yes, you have a tear in your right shoulder labrum, but we think that you should try conservative treatment first because this is a minor tear and we would like to see what Rehab with Ronnie can do for you. So I've already seen him on Monday, Mr. Jerry, for his shoulder pain. I gave him some things to work on, and now it's Friday afternoon and we're following up. I'll give you guys a little insider scoop. At my clinic specifically, it's in a great part of town, but the doors stay locked from the outside. So there's these double glass doors where patients cannot get in. They can't just walk into the lobby. I have to be eyes on the parking lot like a hawk at all times to see when they pull up and then watch them walk to the doors and then be there greeting them when they get there. So first things first, I am greeting Mr. Jerry at the door. "Hi, Jerry. How's it going? Welcome in. Sorry the doors stay locked. It's just for max security, but I'm always here to open the door for you." What a welcoming first impression. You know what I mean? Or I guess second impression because we've met before. But this Friday afternoon, I welcome Jeremy in. We bebop down through the lobby, take a hard right, another hard right, and we're in my clinic. It's been a few days since I've seen Jerry. So I'm asking him, how have things been? How's work been this week? Did you go to the baseball game on Thursday? You know, we're cutting up. We're establishing some common ground. And then he sits on the table. I sit on my stool, laptop open, body turned towards Jerry because I don't know about you guys, but I've been using AI to help me take my notes. And no, this is not an ad for AI note-taking apparati, but it really helps me be way more present with my patient because I'm asking him all the things I would normally ask while tip-tapping away on the keyboard, but I don't actually have to do that. So that's pretty cool. So I'm talking to him and we're catching up, and then I want to know how his shoulder's been. So let's get some good subjective information. How are you feeling? Were you sore after your visit on Monday? I kind of expect him to be if he's a labral tear and then I gave him some exercises. Maybe there was some muscle fatigue. Maybe there was some soreness from the manual interventions that we did. So I'm going to get a good subjective in that way. And then I'm going to ask him how his exercises went because nobody leaves my clinic. Rarely do they leave my clinic without a little home program, 2, maybe 3 things that I want them to be working on that are specific to what they have going on. And the frequency, duration, how many days a week, that totally depends on the patient. Like, rarely am I having someone do something 7 days a week, multiple times a day. It's more so, hey, implement this into your gym warm up routine, or hey, before you go for your run or after your run or whatever it is, do these exercises, see if you feel a difference. So for Jerry, I want to know, how did the exercises go? Were you compliant? Did you download the app? I see that you didn't track any progress. So I really hone in on that. And I'm really not a stickler for if people actually use the app. I just want to make sure that they're doing things correctly. So we'll touch on that for sure. Let's just say, for the sake of this storytelling experience, Jerry's like, yeah, Roni, actually, I was feeling better by Wednesday, Thursday. I woke up with less pain, and I didn't go to CrossFit, but I did go to the Y, and I was able to do not bench press, but the machine press for shoulders because he loves to work his chest and shoulders. And I didn't really have as many symptoms as I normally would. And I'm like, great, Jerry, this is fantastic news. I'm so happy to hear that you already have some neuromuscular adaptations happening in that shoulder, in the joint itself. You are responding well to exercise. We didn't push it too hard on day 1. Let's retest some things. And he's like, you know what? Yeah. The only thing is, I've noticed whenever I'm reaching overhead, I still have this pain here. And he points to a part of his shoulder. And I say, well, why don't you rate that pain out of 10? Always ask for a rating, because if I just write patient has pain when reaching overhead, and then maybe we do some interventions and then we retest it, and he's like, yeah, it still hurts, but less. Hard to measure that if we didn't ask prior to. So when they say, okay, let's say right shoulder, forward flexion, 5 out of 10 pain before we start anything, just him sitting there, us catching up. At the end of the session, I'm going to ask the same thing. I'm going to measure the same thing. He goes, now it's a 2 out of 10 pain. That's good, objective, kind of subjective information to have to keep in the chart to see how the pain behaves over the course of time. So a lot of times on the first follow-up visit, and honestly, many consecutive visits, I like to retest strength because, as some of you may know as physical therapists, a lot of neuromuscular changes can happen in the first few weeks of exercise when you haven't really necessarily been exercising those muscles. And so patients will test, quote unquote, stronger, maybe within that same visit once you give them some targeted exercises, or a week or 2 later. And they like to see that progress too. So I'm retesting manual muscle tests, and I'm informing them of the changes that have taken place. So I'll say, hey, on Monday, this right shoulder abduction was a 4- out of 5. That's how we grade it as physical therapists. And today, you're a 4+, or whatever it is. It's hard for patients to wrap their heads around where they were day 1, how far they've come. They don't remember all the things we're putting their shoulders and arms into all these different positions and doing these special tests, and we're palpating and doing joint mobilizations and potentially soft tissue and taping and dry needling. So they're going to be hard pressed to remember exactly what was what. And so having a good document of what was what and then letting them know is just good. It establishes good rapport, right? I think it does. So let's say some things test better, some things are still painful, as we would expect, 1 follow-up visit later. From there, I kind of let him know my plan. So I'm somebody that enjoys knowing what's going to happen within the hour of whatever visit I'm going to. Like right now, I'm going to a lot of OB visits, and I like knowing I'm gonna meet with the doctor. I'm gonna pee in a cup. Then they're gonna take my blood. Then I'm gonna go talk to the other doctor. I don't know. I just like knowing, and I think a lot of other people do too. Rather than them just guessing, I'm like, okay, first lay down. I'm gonna work on you. All right, get up. We're gonna go exercise. I let them know. Let's say we talked about dry needling the first visit. We didn't do it, but I explained, I think this might help you if we add a little bit of e-stim. It might improve some neuromuscular recruitment of those rotator cuff muscles. And Address the trigger point in your infraspinatus. Guys, I'm just literally throwing stuff at the wall right now, but you get the point. Let's say I rationalize a manual treatment. I'm going to tell him, this is what I want to do. Then we can retest that painful motion that you were just describing. And from there, I want to look at how those home exercises are going. So I want to do a few and just make sure everything looks okay since we've only gone over them once before in person. And then I want to progress some things today to make sure that we can keep working towards your personal goals and get you out of here ASAP. For the sake of time and context, I'm not going to delve into every single manual intervention that I would or could do. I wouldn't say I'm heavily manual based, but I would say I'm a good mix. It really just depends on the patient and what they are expecting out of a session and what I think they need and what's appropriate at the time. So sometimes maybe I am dry needling. Sometimes I'm working on their neck. Sometimes we're taping, or if they've expressed that in the past they like cupping, maybe I'll do that because they believe that it has helped them. So that's up to your discretion. I'm not here to offer professional advice about what's going to work or what's not going to work. I think a lot of physical therapists understand that the research behind manual interventions is like, does it work? Does it not? When combined with exercise, the exercise populations always do better. So I'm always going to err on the side of let's make sure we're doing our exercises, but also let's make sure that this is an enjoyable experience and they're feeling better. And a lot of times that hands-on treatment feels better. As I'm recording this, I'm realizing that I talk kind of fast. I had a direct message a couple weeks ago, and granted, this person was from out of the country, and they did ask me, "Hi, Roni, I really appreciate your content. Do you mind talking a little slower in your voiceovers because I can't understand what you're saying? English is not my first language." Uh, and so I kind of think about that now when I'm chatting. I am a little over analytical of my pacing of my voice. So hopefully this isn't too fast for people that are listening. Let me slow it down. Okay. So, manual interventions have come and gone. Jerry sits back up. I'm like, "How you feeling, Jerry?" He's like, "I'm doing good, Ron. I'm doing good." We retest his shoulder flexion and he says, that feels a little bit better, but now it's sore. Like it's not a sharp pain, but I'm feeling some soreness." And I go, "Oh, yeah, well, that could be from the needling that we did in your shoulder." And he's like, "That makes sense." So then I say, "All right, let's walk on over to the exercise room and reassess those exercises I gave you on day one." So we mosey on over to the other room. My clinic is set up like I have I call it exam room, but it has my high-low table, my plants, my comfy leather chairs, my rolling desk, uh, some of my evaluation equipment, like my little rolling cart of dry needling and tape and goniometers and blood pressure cuffs, all that fun stuff. So that's where a lot of the magic happens, but we do meander on over to the exercise room pretty much every session. So we go over there and he shows me his exercises and I check his form, make sure everything's looking good. If it's necessary, we'll progress them. Let's say one of the exercises, let's say his push-up plus is easy. He's like, "I don't feel this anymore." And he was just doing it in quadruped. He was doing it on all fours. I said, "Well, let's get into a high plank position." "Oh, that's still not challenging enough. Let's actually add a little push up." So you're not just getting that serratus anterior. For those of you that don't specifically know what I'm talking about, this is like a very much a PT term. So I apologize. I try to make this content applicable to the masses, but when I'm detailing out a follow-up visit in a PT clinic, it's hard not to go real deep. Anyways, I want to progress exercises. At this point, it's probably, if his appointment was at 8 a.m., it is 8:35, 8:40. Okay, so we've got about 15 minutes to add a couple of exercises and then cap it off back in the exam room. My employee that I recently hired had an interesting insight, and I want to just bring this up because I think it's relevant to my visits. She said, "It's interesting how, with your daily visits, your follow ups, you only give them like 4 exercises. We might only do 4 exercises over the course of an hour." But she was saying they're so specific and they're obviously so targeted to what that person needs. at that time, that you're not throwing in a bunch of other fluff to fill up the space. And I agree with her on that. I think when I was working in an outpatient clinic, I found myself often trying to hit a number. Like, let's say for a total knee replacement, I was just trying to get them to do 8 exercises, like, in a row. And I think part of that was just to maintain some time management and make sure that everybody else was taken care of and I wasn't just only paying attention to one person. But when you have the opportunity to work in a cash-based clinic like mine and be one-on-one with patients, you really can sit down and mull it over and really make the exercise specific to exactly what they're trying to accomplish. And again, like that totally depends on the person because if Jerry is trying to get back to snatches at CrossFit with his shoulder, there's going to be a nice linear, hopefully, progression of the way the exercises will go. If Susan has just generalized pain from knee arthritis, it might be a little less specific, but I think you guys get my point. Like, it is nice to have autonomy and creativity and the time to look at the patient in front of me and say, this is what I think is going to help, and then educate them on why. So I'm glad that I'm going down this little rabbit hole here because I think the why is important for you as a physical therapist, as a clinician to sort of double down and explain to yourself out loud why you're choosing this exercise. And then the patient isn't then sitting there just getting thrown exercises at them without understanding how it applies to their recovery. So for Jerry, I'm going to say, okay, Jerry, we're going to do this overhead kettlebell carry. I want you to walk and hold this kettlebell overhead, and we're going to go for 10 laps. And I want you to do that because I want to get the shoulder used to stabilizing in an overhead position. Because what do we have to do during a snatch? You guys get where I'm going with it. So I don't do that for every exercise every time, but it is nice to clue people in a little bit on what your thought process is. And although they probably aren't going to remember exactly why or what it is you're doing, it helps them, it reaffirms that you know what you're doing and they feel confident in you. And it's trust building at the end of the day. That's what we're doing. All right. So the exercises have commenced. We're finished. He's broken a little bit of a sweat on this Friday morning and he's feeling kind of good, kind of pumped up. He's like, I think I could go to the 12 p.m. CrossFit today. And I'm like, no, Jerry, don't do that yet. We're not there. I know you're feeling good, but let's talk about rest. Let's talk about controlled rest and the appropriate way to load tissues over the course of time. And so maybe I throw in a little bit of patient education there on the back end of the visit. And then we head back over to the exam room. He sits down. I explain what's happened during that session. Like, hey, you tested stronger with shoulder flexion after these exercises. Oh, let me backtrack really quick. After manual interventions and often after exercise, I am retesting. So the whole theme of my follow-up visits is like test, treat, and then retest. And for Jerry, it is painful shoulder flexion overhead. I'm going to test that. I'm going to treat it manually. I'm going to retest. Maybe a 2-point pain difference change, but let's just say range of motion still limited. We're going to address that with some exercises. We're going to test. We're going to treat it with exercise. We're going to retest. And that, again, to my point earlier, shows them what physical therapy intervention can do in the short term, and then hopefully in the long term as we continue to pile visits one on top of the other. If you're not testing, treating, and retesting, you also don't quite know what you're doing, right? Like if I just throw a bunch of things at him and we do it, and then he leaves, and then he comes back the next week and says, yeah, I don't know, I'm kind of in more pain. I don't know. I don't know what it was. Could have been something I did, could not have been. Maybe he comes back and he's feeling a lot better. And you're like, well, shoot, which one was it? So if you take anything away from this episode, I would say test, treat, retest. Some people say assess, treat, reassess. Whichever it is, however you can weasel that into your brain and keep it there, sear it into your brain, whatever verbiage you need. I think that's very, very important. If you don't do anything else during the follow-up visit, do that. That's important. Jerry's going to be excited to see changes that happen inside the clinic. So I digress. We have finished everything. We're back in the exam room. I'm like, okay, Jerry, this is what we just did. This is what I plan on doing next. So I always include a plan for the follow up visit. Sometimes people are scheduled out. Maybe Jerry said, hey, I just want to go one by one. I don't want to buy a package. I just want to see how this thing goes. And I tell him, okay, I want to see you 2 times next week. And this is what I'm planning on working on Tuesday and Thursday of next week. That way, again, to reiterate, he has a pretty comprehensive plan of what it's going to look like for him when he comes in and what he should be working on at home when he's not in. One thing I do that I think might be a little bit different compared to outpatient clinics is I will update their home exercises pretty regularly. I use an app. It's integrated with Jane, which is my billing documentation EMR system. So Jane is my documentation, and then Fizzy app or Fizzy track. I think Fizzy app is for the patient and Fizzy track is for me to add. Either way, I go onto that app pretty often and update things. One, because I want them to gradually be doing a little bit more and more. Two, because they get pretty used to some of the ones that were maybe beginner level in the beginning. And so I like to progress. And I feel like, I don't know, I feel when I was in big outpatient clinic, I would kind of forget about their home exercises. Ashamed to say it, but I would forget about them. They would forget about them. Not all the time, but sometimes it would be 2 weeks before I would progress something, or 3 or 4. And I hate to admit that, but that is the truth. So maybe with Jerry on this one follow-up, I'm not updating anything yet, but I'll say, "Hey, by the end of next week, I expect that we're gonna progress this home program, so you're feeling good and we're moving right along." So, just a little thing that I like to add. Before he heads out the door to enjoy his nice weekend with his family on the boat, I'm just, like, making up an entire life for Jerry. He has it pretty good, honestly. He's a pretty fit guy. He's got a boat, a tri-tune, actually, and he also likes to wakeboard. So I told him, no wakeboarding this weekend, but you can drive the boat. Oh, this is so random. But, anyways, before he leaves, I always say, do you have any other questions for me? We covered a lot today. Any questions for me? And sometimes people do. Most of the time, they don't. I mean, at this point, we spent a solid hour together. They're like, no, peace out, bye. But people like Jerry, they're really active and he wants to know, yeah, hey, can I bench press max with my buddies this Sunday? And I say, no, you actually can't. But here are some of the things that you can do to get you back there eventually. So, in closing, I think 2 main takeaways here are, say it with me, number 1, test, treat, retest. Don't forget that, please. And number 2, I haven't said this one yet, but someone said this to me one time when I was in clinicals. She was another therapist working at the clinic. She was not my CI, but she said, I treat every follow up visit as an evaluation, like a reevaluation. And that stuck with me. That hit so hard. I was like, you know what, girl? You're so right. Because maybe you thought it was one thing when they came in on day 1. And then they come in the next time presenting a little bit differently. And you need to sort of take a step back, assess. So keep that mentality. Obviously, you can't do an initial evaluation every time somebody comes in. Like, you kind of have to go with one narrative and subscribe to that for a little bit and see how they respond. But it is nice to know that as a PT, you can change course and you can continue to question yourself and retest things and be curious. That's the fun part about the follow-up visits. It doesn't have to be set in stone after day 1. Like, okay, he's a labral tear. This is what we're going to work on. Maybe there's some neck stuff going on too. And maybe we also need to work on his rib cage mobility and thoracic mobility. There's a lot of other little components that go into treatment that make it exciting and make it fun. And I think I know that that's much more doable in a setting like mine. And this is not me out here bragging about how, oh my gosh, cash-based one-on-one PT is so much better than everything else, but I'm able to talk about all this in this lovely way because this is my experience now. It wasn't always. But regardless of where you work or what setting you work in, I think there's definitely some takeaways that you could glean from this episode. And so I hope you have.
And as always, I love when you guys write in and give me ideas to talk on because I love having guests on, but I also love just kind of getting down and chatting with you one on one. So I don't know that I have tons to offer, but when you give me good ideas like this, it's kind of fun. In closing, give me a little 5-star review if you're interested in that. Maybe a little comment on the episode if you want to make my day. Make sure to, I don't know, like, subscribe. I don't even know if you can do that on Spotify or Apple. Show me some love because it makes me happy. That is the main reason why. And I look forward to chatting to you guys next week. Bye.